Uh, Welcome to the National Foundation of Swallowing Disorder webinar series. My name is Ed Stever. I'm the president of the foundation and also a head and neck cancer survivor. I'd like to welcome all of you here this evening. The mission of the National Foundation of Swallowing Disorders is to improve the lives of all those with a swallowing disorder. And we do that through four pillars: providing direct patient support, and we do that through referrals globally, support groups, online forums, and connecting patients to medical providers. We also raise dysphagia awareness, and I'll come back to that in just a minute. We deliver educational programs, such as the program this evening on transitional foods, and we support promising dysphagia research. Next slide, please. I'd like to take a minute and talk about raising awareness. As many of you may know, June was National Dysphagia Awareness Month, and our executive director, Elizabeth Lipton, has led this initiative for the past few years, and from my perspective, this year was absolutely the best. We reached close to 1 million views on our website and social media platforms. We hosted a t-shirt contest, and we've had 90 design submissions, and the shirt we ended up with, I'm hoping you can see it, but it says dysphagia, and some things are hard to swallow, but we ended up selling about 300 of these shirts in May so that people would have them in June. We also started the month with about 15 patient stories. And the slide that you see up right now is a collage of 22 patient stories that we ended up with in June. Once people saw that we were doing patient stories, they wanted to tell their story either as someone with a swallowing disorder or a caregiver for someone with a swallowing disorder. And our sponsors pitched in by funding this every time a story was shared on Facebook or Twitter. And so I just want to take a moment to recognize all the people who stepped up and told their story, and we're just excited about having their story told. Two other short stories about June. I was out for a walk with a friend who was wearing the shirt that I have on, and it was a neighborhood walk, and a woman stopped us and said, "I've never seen a shirt with dysphagia on it before." And she turns out to be a speech language pathologist in the neighborhood, and it was just a nice way to meet someone. And I think that's it for this slide, but I do want to thank everyone that did submit a story. During the course of tonight's webinar, you will be muted during the presentation, and to ask a question, click on the blue question mark to type in your question at any time, and our keynote speakers will get to them during the presentation. The NFOSD is honored to recognize Bracco Diagnostics as a sponsor of the Dysphagia webinar series. Their unrestricted educational grant to the foundation allows us to offer this webinar free of charge. We also would like to recognize our Dysphagia webinar series corporate sponsors, Clear, Dysphagia Aid, Medcoat USA, and Mira GTX. It is only with the financial generosity of our corporate sponsors and community members that we're able to advance our mission. I'd like to introduce you to tonight's volunteer guest speakers, Dr. Reva Barrell and Dr. Samantha Shute. Reva is a dentist, trained culinary chef, an expert on dining health whose passion for food and science stems from her childhood eating challenge related to a jar growth deficiency. She's now an accomplished speaker, researcher, educator, author, and business owner. Samantha is a speech-language pathologist and assistant professor at the University of Oregon with expertise in the effects of healthy and pathologic aging on swallowing and the mealtime process. Samantha also hosts a swallowing disorder support group in Eugene, Oregon. And I don't know how many of you are familiar with Saturday Night Live TV show, but they actually have what's known as the 5-timer club for people who have hosted Saturday Night Live 5 times. Well, Samantha is hosting for a second time, so she has a little ways to go, but we really, really appreciate that she and Reva have volunteered their time tonight to share their expertise to be with us, and we do appreciate their generosity. So at this time, I'm going to turn it over to Reva. Please ask questions as we go along, and I'll see you at the end of tonight's presentation.
Hi, I hope you can all hear me. Thank you so much, Ed, for your introduction, and Elizabeth for your support. You are both wonderful in bringing together the community with speakers and developing a stronger network on this very important topic of dysphagia. And I wanted to just start out with an introduction of the presentation. The title is Transitional Foods, Updates on Their Behavior, Use, and Benefits in both the adult and pediatric populations. Both Samantha and I do spend more time in the adult population, but there is so much crossover and benefit to talking about both populations that we felt that there were nuggets of information that would benefit clinicians in the adult and the pediatric space. So thank you so much for joining us today, and looking forward to hearing your questions as we go through this program. So the next thing that I wanted to talk about is our disclosures. Included in the presentation are findings from research that was partially funded by my company, Taste for Life. And Taste for Life is a mission-based company focused on research, innovation, and education in transitional foods and puree foods. And we have created a food product that we are going to be bringing into the presentation called Savory's Foods, because there are transitional foods in that product line. So we have a lot of background in transitional foods because of this. Dr. Samantha Schoon has an ongoing voluntary advisory relationship with Taste for Life. So I just wanted to introduce us a little bit further. Ed, you did, thank you so much for that introduction. It was great, and I just want to add a little bit of flavor, if you will, to our topic, and that is the fact that I was a very happy dentist working away in prosthodontics, which is full mouth reconstruction. And it just dawned on me one day when I was working on a wonderful patient of mine that had head and neck cancer. And I did a full mouth reconstruction on her. And she said, well, this is great, Dr. Barrawal. You have made me able to chew my food, but unfortunately, I am on a texture modified diet. So I have dysphagia, and it was an awakening for me. It was like just being hit on the head with the idea that I knew everything about the mouth, but I knew nothing about the swallow reflex. And I just couldn't put it to sleep, because there I was as a culinary chef that understood the importance of food and how food played into our culture and the importance of teeth and smiling and mastication, but I didn't understand about the swallow reflex. So I spent 7 years now, that journey started 7 years ago. And in that journey, I met Dr. Schoon as I was giving out a survey at an Oregon Speech and Hearing Association conference. And there she was, and we started talking, and it's just burgeoned into this wonderful relationship. I am going to let her give her introduction as well. And first, I'm going to just say what I'm going to be talking about today. So I'm going to cover the first part of this presentation, and I'm going to speak mostly about food sensory science, because I think this is a really interesting collaboration. Transitional foods brings together many different disciplines, and I think it will provide a lot of understanding for the audience. I'm going to talk about basic definitions and the advantages of solid foam transitional foods, and the value of finger foods and snacking, as well as touching on some studies in the pediatric space on first finger foods. I'm going to ask Samantha if she would like to talk about her portion of the presentation and her background.
Yeah, thank you, Reva. So then we are going to switch over a little bit just to give you all a heads up. We'll have a short opportunity for a few questions in between. And then I am going to be talking about my portion of the presentation, covering IDDSI tests for transitional foods, oral environmental influences, a dissolution study that we completed in older adults looking at transitional foods, and then further studies looking at finger foods and snacking. To give you all a little bit more background about myself, as has been mentioned, I am a speech-language pathologist by training. I am a faculty member here at the University of Oregon. I do research in swallowing and swallowing disorders, and really my focus is on taking a more comprehensive view of the eating and swallowing process, where transitional foods fits nicely within that space. How can we maximize health, safety, and quality of life for individuals with dysphagia across the lifespan? So I look forward to chatting with you all a little bit more, and I will now turn it back over to Reva. Thank you.
Great, thank you, Samantha. So the next slide we have is a really wonderful TED Talk that was given by Dr. B.J. Miller. And the title of the TED Talk was What Really Matters at End of Life. And what I loved about this presentation and the words that were used in this particular portion was it really focused on the dignity by way of the senses. So I'm just going to read it out to you right now, what Dr. Miller said. Probably the most poignant room in the Zen Hospice guest house is our kitchen, which is a little strange when you realize that so many of our residents can eat very little, if anything at all. But we realize we are providing sustenance on several levels. Smell, a symbolic plane. Seriously, with all the heavy-duty stuff happening under our roof, one of the most tried and true interventions we know of is to bake cookies. As long as we have our senses, even just one, we have at least the possibility of accessing what makes us feel human, connected. Imagine the ripples of this notion for the millions of people living and dying with dementia. Primal sensorial delights that say the things we don't have words for, impulses that make us stay present, no need for a past or a future. So the next slide is called sensorial delight. Although Dr. Miller was describing the particular sense of smell with the cookies to conjure up happy memories, transitional foods give the person a food they can hold on to, crunch into, and provide a very different visual connection as compared to a puree or thickened liquid. In fact, at ASHA last year, someone said to me that transitional foods are perfect for pleasure feedings. And as a dentist and culinary chef entering the world of SLPs, the term pleasure feedings made me realize how changed the dining experience can be with dysphagia and the importance of these primal sensorial delights. So when we look at the sensory experience, we can see that, of course, we all know we have 5 senses, right? And when we perceive and evaluate food, it is affected by engagement of all 5 senses: taste, vision, olfaction, audition, or hearing, and touch. So the typical problem with a texture modified diet is that compensation can be made to improve taste, visual appearance, and smell of the foods with puree and minced moist foods, but the area of sensory deficit is in sound and touch. Using a utensil like a fork, knife, or spoon is called indirect touch. And that, you know, the textures of pureed foods that have been published, really the pleasure is not as great with puree versus a solid food. So with taste and smell, sight and hearing perception diminishing with age, transitional foods can make food consumption more pleasurable because it can engage sound with that crunch and touch where puree cannot. So transitional foods actually bring texture to the diet. I had a conversation recently with Dr. Lisa Dweezer, who is, you know, a published author in this area and speaker in food sensory science and long-term care. And she shared her opinion that puree foods would have a different flavor profile because the volatiles within food, the volatile odors within and tastes within foods are released when you process that food, when you make it into the puree, which means in the kitchen. In the solid food, the ones that you put in your mouth, the cell walls are broken inside the mouth, so the cell walls of the food product itself. And so those volatile compounds are released in the mouth, and we perceive them with olfaction or taste. So I just find this really interesting because when we talk about the flavors of puree and the dulling of the flavors of puree, we can really understand now the why behind that. And it would be really interesting to find out about transitional foods, which are kind of like that middle territory between solid and puree that we'll get into later, and find out how they behave as far as releasing those volatile compounds. So the other question that I bring to you is, do we all have our own texture preferences? Like, do certain conditions lead to texture preferences? And what I'm going to do is share with you this wonderful image, and it comes out of a publication by Geltima in 2014. And what is super interesting about this is that the realization came that people have different texture preferences. So what they did was they were looking at foods in 4 main categories. And if you look at the titles of these categories, the one on the top left is, I like foods that I can crunch. And on the top right, I like foods that I can chew. The bottom left, I like foods that I can suck on for a long time. And the one on the right, I like foods that I can smoosh. And you can see the different examples that were given. So what we don't know is, what I should start by saying is the conclusions that they found were that the majority of people like foods they can crunch and chew, but there were some people that actually preferred foods that they could dissolve in their mouth that were more like hard candies, or things they could smoosh like puree or the soft ice cream cone or the soft ice cream. So we don't know why people have these preferences, but are they inherited? Are they learned? But it really sheds some light on, what people, maybe when they have a texture modified diet, how, some people might be more receptive to that diet and some people might not. And you might want another card, if you will, to pull, which transitional foods can help with. When I did look at some research on Down syndrome, I also found that when you look at specific conditions, people do have preferences for textures that are easier textures. And specifically in younger Down syndrome, they showed that they had a preference for creamy, crispy, crunchy, dissolvable, and mushy textures. But those chewy and hard textures were harder, and they kind of steered away or developed texture aversions. So that, is looking at subset populations, and we can learn a little bit more of the general population, but also when there's a condition at hand. So what I wanted to talk now about is innovation, because I'm all about innovation in dysphagia. I'm passionate about it. I wanted to share with you that there's really exciting things happening with puree in the form of looking at the visual appearance of puree. How can we make that plate look more palatable by molding foods or piping foods and even 3D printing foods? They're also looking at improving nutritional value of the foods as well. And I'm not going to focus on how they're doing that. I'm going to now shift gears to the transitional food. Well, there's lots of innovation there as well. It's really more about how do we make these transitional foods, or these, I would call them almost, that crossover of a crunch and then a dissolve. How do we make them stable? And how do we make them more rapidly dissolving? What ingredients can we put in them to stabilize the product? But also what ingredients we can put in to improve nutritional value and use less processed ingredients and more real food ingredients. But step back a little bit and you can see now the images. You can see the ones on the left are more like a plate of food, and puree tends to focus, puree innovation is focusing more on that main meal, the plate of food, whereas transitional foods focus more on snacking foods. Now we have this wonderful thing called IDDSI, the International Dysphagia Diet Standardization Initiative, which actually helped us define what is a transitional food. So if you look at the diagram that I'm sure many of you are aware of at this point is the IDDSI pyramids. So the inverse pyramid is for the foods, and we can see there that the transitional foods are hanging off on the left-hand side there. And they kind of stop right at the level 5. So they start at regular and they end at minced moist. And what they're trying to say is that transitional foods start at one texture but change into another texture. And typically the properties that cause this change are having moisture present, whether that's water or saliva, or a temperature change. The other criteria for a transitional food is that no biting and minimal chewing is required. So it's simple tongue pressure. There's no size restriction, and the degree of texture transition is variable, but must at a minimum pass the fork pressure test. And Samantha's going to go into detail about that. You know, what I wanted to share is I really like the term transitional food because it's not only describing the physical characteristics of this food group, it also has a secondary meaning. It really is talking about the transition of that person and how this could have a therapeutic meaning. Let's say, for instance, that in a rehabilitative sense, as they transition from one texture to another, it can provide training or experiential learning for that individual, whether they're a child or an adult. It can help with transition from, say, tube feeding to a solid food diet in the pediatric space. And actually, historically, these foods have been used in the pediatric population for those with less developed chewing motor systems. And there are a lot of products out there that are called transitional by IDDSI. Foods like Gerber Graduate Puffs, the Baby Mum Mums, Rice Puffs, Cheeto Puffs are all considered transitional foods. But what's interesting is that adults face issues related to chewing when they have reduced number of teeth, when they have dentures that don't fit. They can have dysphagia, which can affect their oral control or decreased tongue lateralization, and transitional foods can fit their needs as well. So when we look at transitional foods, you can see on the left, I have described them as solid foams, and you can see images of solid foams. And the ones on the right are described as solid gel or liquid. So if we look at solid gel, the gel or liquid solid states tend to be more dependent on temperature than additional moisture added to them to change. So the solid foams on the left are stable usually at room temperature and tend to remain so with temperature. But when you throw in moisture with that temperature or just moisture alone, that's when you see that transition happen. Examples of the solid foam are Savory's crackers that are on the left, the Baby Mum Mums, shrimp chips, or you can see them, the colorful chips on the right, Cheeto Puffs, veggie sticks, Eat Bar, and some cookies, shortbread cookies. The solid gels, ice chips, that's considered a transitional food. The Magic Cup that you can see an image of, ice cream transitions that we all know about, and this interesting Japanese dysphagia training jelly, which transitions also to a liquid state. So the question is, what degree of transition would you expect? When you have your patient, what can you expect from that transitional food? It's going to start, perhaps, if we're going to just talk about the solid foams right now, they're going to start as a level 7 or a regular food. And what they transition to depends on each product. Some will transition to a 6 or a 5 or even a 4. But what it offers you choice, right? I think that's the important thing. If a patient, for example, is on a minced moist diet The food options could also include a transitional food that transitions from a regular food to the minced moist food, or even if they transition further down and dissolve to a puree. So, it's important to understand the why behind this variable transition between different products, and then decide what is right for your patient. It really is a play between how each product is made and the environment they're in. I think you have capacity to control or evaluate the environment of the transition that the transitional food is under. And Dr. Samantha Schoon is going to go over this in detail with you and give you the tools that you need to make those decisions for your patients. I wanted to categorize because I like to take the dysphagia or texture modified diet and put it in context of what patients' previous experiences might have been and how we can connect the dots for those patients with transitional foods. So although transitional foods are defined for the texture modified diet, they actually fit into a category of finger foods. And if you go more broad than that, finger foods fit into a category of snack foods. But clearly, like, not all snack foods are transitional foods. But what you can see here is that there is an opportunity for someone on a texture modified diet to eat a food that not only resembles a snack food, it is a snack food. So why is this so important? Well, there's a picture here of an aisle in a grocery store in Portland, Oregon, which shows the snacking aisle, and it is pervasive in our culture. We love snacking. But when you have a texture modified diet or you're in facility care, snacking loses its importance. We've seen transitions within the general population where snacking used to be empty calories, but now there's so many new different types of snacks on the market. So it's not just an empty calorie habit anymore. It is an opportunity to improve caloric intake. And frankly, we're not utilizing it enough for people with dysphagia or slow eaters. In fact, literature shows that by improving opportunities to eat and drink from 3 times to 5 to 6 times per day can lead to residents' overall daily consumption in long-term care. And 2 studies investigating the effects of providing energy-dense meals and snacks to hospitalized patients showed an improvement in nutritional status and in body weight. There was also another study that showed a shorter length of stay with implementation of snacking. So it makes you start to think. When you start to hear about research on plate waste in long-term care facilities, and there is a PPD, or the amount per day on food, and if you're spending, let's say for example in a facility, $12 a day on meals, but there's up to 2/3 plate waste, it would make sense, in my opinion, to reduce the portion size of the main meals and introduce more nutrient-dense snacks to help reduce waste, but also increase eating opportunities. Finger foods is just amazing, the recent research on finger foods and their importance. The sense of touch is the first sense to be developed in the womb, and it's the last to lose with age. So if we can increase pleasure in eating and consumption with direct touch, this is really of great benefit to people with dysphagia who are more at risk for decreased food enjoyment and malnutrition. Mazarov is from Food Sensory, and they weren't talking about dysphagia, but this study was very interesting because it showed that when people were able to physically touch the food, meaning use finger foods instead of a fork and a knife and a spoon, it enhanced the sensory experience. Touching the food actually makes the brain think it is tastier and more satisfying even before it reaches the mouth. So they were studying people with high self-control, and it's like more people that watching what they eat, more calorie watching to reduce their calorie intake. And they found that when they introduced finger foods as opposed to not finger foods, people ate more quantities of food. And it's interesting, if you're looking now at a population where we're really concerned about malnutrition and unwanted weight loss, and yet the dysphagia population, in some cases, they're really watching what they eat. And you know, I'm going to suggest something that this is going to be a benefit if we can get them to eat more food, because finger foods elicit more of that reflex to think it's tastier and to continue to eat. I think that could be a real positive in dysphagia space. So Heelan just published an article saying that the use of finger foods can increase, and it may increase, nutritional intake and enhance eating independence and well-being for adults with cognitive impairment in long-term care settings. So if we look more broadly at the advantages of transitional foods, I divide it into 3 components. There's the psychosocial component, nutritional, and I couldn't think of a better word, so I just said simplicity, the simplicity component. So if we first talk about the psychosocial, we can see that Dr. Dweezer that I mentioned before and Dr. Keller have done numerous articles showing that texture boredom is a real problem with puree. And we need to have more of a person-centered approach to feeding and to options that really target their needs and more choices. We need to start thinking about supporting eating independence. Finger foods would definitely fall into this category. And there is, if you can eat independently and eat food that other people would enjoy, then that increases your mealtime dignity. The attractiveness of the food, if you look at that puree and that wonderful molding that's done, the problem is that when they start taking bites of that food and the food gets mixed together on the plate, that attractiveness goes away. Whereas with transitional foods, because they're intact at room temperature, that the solid foams don't lose their attractiveness with time or with consumption. And if you can think about the pediatric population, I've talked to SLPs that are specialized in the pediatric space, and they were talking about their moms that talk to them about snacking in the playground for their children that have special needs, special textural needs, and the parents' desire to provide their child with special textural needs, foods that look similar to what other children are eating, and also that other children would want to eat. And so I feel like there's a big psychosocial component here that can be an advantage for transitional foods. When we look at the nutritional value, there is a lot of info on puree nutritional value and how to fortify purees, but there's also a similar discussion happening with transitional foods. The belief is that transitional foods typically, historically, are not high in nutritional value. And the difficulty with transitional foods is that they're a foam. It's a solid foam. And so it's hard to pack a lot of nutrient density in a solid foam. And if you look here at the different products, you can see the top 4. I divided it up to show what the serving size was. And you can see baby mums in those 4 rusks. There aren't really that many calories there, not that much protein, fiber, and very low sodium. So really kind of not very robust. And I think that there's avenue here to improve what we have for nutritional value. With the savories crackers, we really made an attempt to put real olive oils in there, real vegetable purees, amp up the protein with good pea proteins, and try to keep the sodium low. So I know that that is really a focus and a future direction of transitional foods, is to now start looking at the macro and micronutrients and where is the nutrition coming from, and trying to get away from highly processed ingredients and more towards natural ingredients. I threw in applesauce at the end because on every cart in every facility, there will be applesauce. And when you look at applesauce, you can see that there's really not much protein there. There's a lot of sugar. And I think transitional foods offer the savory flavor enjoyments. So back to that choice and improving choice for individuals. Next is on simplicity of foods. And I would say that if you look at the top of the slide, you probably are very much aware of the 6, 5s, and 4s and what you need to do to foods to change their texture. There's a lot of pressure on the culinary staff to make this accurately, especially with the IDDSI implementation, and to look for options where things are more ready-made. Now, if you look at transitional foods and you look at even the home chef who's trying to make these foods for their loved one, you can see how having something that's convenient, which transitional foods fit that criteria. And maybe you could look at that plate a little differently. Maybe you could have 3 instead of 4 purees on that plate or minced moist, and you could have a transitional food that's nutrient dense on that plate as well. Or if they're going to an appointment, they could take something that would satiate them when they're on the go. I'm going to touch briefly, and I wanted to show this slide with this coloring page that came from Dysphagia Awareness Month. I wanted to thank Elizabeth for sharing savories with this coloring page and offering that to the community. But it reminded me of cognition and the benefits of mastication. So I wanted to, I'm putting my dentistry hat on here, which I think it's really great to cross-discipline in this conversation and look at a little bit at what I've studied in the relationship of mastication and cognition. There are animal studies which show that when you lose chewing function, like they take away the molars from mice, that you see cognitive changes. And I want to share with you that human studies have been done which show empty chewing. So if someone doesn't have good chewing habits, then you see a decline in memory. But when they have empty chewing, meaning there's no food in their mouth, but they're doing the up-down motion of chewing, you could actually see in limited studies, I would say, improvement in memory. So there is ample room here for more studies, because what I think is that it is a primal response to take a solid food and put it into your mouth and start chewing, even if you don't need to chew, as in the case of transitional foods. So if we can capitalize on this primal response, is it possible that we can have perhaps a cognitive benefit, especially in the realm of dementia? And I think this bodes further study. And on an anecdotal note, in talking to a company called No Tube, which originated in Europe, they are trying to promote a tube feed weaning for children. And they saw that when they did early mastication, they introduced early mastication with transitional foods, they saw improvements in gross motor skills and memory. And again, this requires more study, but it's an exciting area to contemplate. So my last couple of slides here are going to talk about pediatric first finger foods. The studies on transitional foods really started in the pediatric space. And this is a really great study that Samantha's going to go into more detail on. But what I wanted to share is just the early introduction. The AAP recommends that first finger foods, should follow 3 criteria. They should be soft, easy to swallow, and infant bite-sized. So what they did was they decided to study 9 branded first finger foods. So 8 of the 9 products were marketed by Gerber, and the 9th product was something that I'm sure many people know, it's Cheerios, and they used adult testers, and the adult testers flagged when the product became soft in their mouth, they raised their hand, and then when it dissolved completely, they flagged again. And then they also looked at foods that were left, these finger foods, left in the air for 1 hour. And then they compared those to the fresh products. So what was interesting was some of the products that were, when exposed to air, changed texture. They were initially marshmallow-like instead of that crunch and dissolve. And then some of them became in the mouth more like hard candy. The dissolve rate was very variable. And so I'm just going to share that there was a lot of variation in behavior of the products. And Dr. Schoon's going to talk more about this, but I wanted to discuss one takeaway. And that is, if you are going to offer transitional foods to your patients, understand that all packages should be kept well sealed if saved for a later date. They all are manufactured in a way that is a dehydration, so getting rid of the moisture, or a slow bake process. And if you leave them out of the container for a long period of time, then they will change consistency. And you want to know what it changes to. So I think it's important to educate and tell them to eat in one sitting is what I say. Just have single serving packaging if you can, and ensure that the parent or the person with dysphagia knows that they need to eat in one sitting, and that there is tremendous variation in the different brands. And with that, I would like to hand off to Samantha to go into more details on recommendations and as well as the studies and implementation.
Before Reva hops off, I just wanted to take a minute because I'm going to switch over my slides. So if anyone did have a question or two about the material that was covered thus far, I think you'd be willing to answer. Is that correct?
Yeah, absolutely.
I'm just going to switch over my slides.
Cool. Reva, there's a couple questions that came in. The first one here is asking for some clarification. They're wondering about the IDDSI levels 5 and 6. Do they have size restrictions of 15 millimeters? Do you know?
For the transitional foods, actually that's an excellent question that Samantha is going to cover in her presentation. So there's more to come on misconceptions about the size requirements for transitional foods. And so, you know, I don't want to steal her thunder, if you will. So I'm going to leave that to Samantha to discuss on her slide presentation, but it's an excellent question.
Okay, and I'll ask one more here during the transition. The other question that we have right now, it says, how do you measure nutritional values for foods like steamed carrots?
So that's a great question. I think, so there is something called ESHA formulation. So food scientists, they rely on that to determine nutritional value. If you're asking about the home chef and how they would understand that, if you go online, you can find resources. If you just typed in cooked carrots nutritional value, you can find websites that can give you the breakdown. If you want to dial into a specific recipe, I think that you would have to go more into formulations or more into discoveries about each individual ingredient, which can get more onerous on the individual. But I found that just Googling that it gives me ample information if I'm not going to manufacture a product, let's say, and require more dissected information.
Excellent. I'll stop here for questions. There's a few more that came in, but we'll save them till the next Q&A section. So Samantha, go ahead. Thank you both.
Wonderful. All right, so we're going to shift gears a little bit and talk more about the implementation of transitional foods actually into clinical practices. And in particular, I'm going to target what we currently know based on the literature and how that information really can help guide our practices. So for those of you who may be a little less familiar with the International Dysphagia Diet Standardization Initiative, or IDDSI, each level of liquid and food that Reva introduced earlier has a specific testing method, or sometimes multiple methods that are possible that are associated with it. However, transitional foods pose a little bit greater difficulty as they do start one texture and end as another. Ultimately, what we are likely most interested in when discussing patient safety is what the product will transition to after being exposed to body temperature and moisture in the mouth. And so in order to simulate this process, the IDDSI food testing methods document that's available online does outline the procedure for the fork pressure test, as I've shown a piece of it here. And so first, you will expose a 1.5 by 1.5 centimeter sample of the product to 1 milliliter of water, and then you wait for a minute. And I think this gets at the question that was brought up earlier. A clear clinical misconception comes up when we talk about testing transitional foods. So this 1.5 by 1.5 centimeter sample that I mentioned is not the size that the food item needs to be. This is the size used for testing the product. So again, it's coming up with a standardized sample size for testing the product for appropriateness or determining appropriateness of whether it's a transitional state food. And I'll talk more about the level 5 and 6 in a moment as well. But going back to the testing for a moment, once the sample has sat in this liquid bath for approximately a minute, you would then complete the IDDSI fork pressure test, in which you're actually pressing down on the sample with a fork until the thumbnail blanches white. And so a transitional food is then defined as one in which after moisture or temperature has been applied, the sample can be easily deformed and does not recover its shape when the force is lifted. So here's an example of what that might look like. And so then we would say the sample is a transitional food texture if after removing the fork pressure, the sample has either been squashed or disintegrated and no longer looks like its original state, or it has melted significantly and no longer looks like its original state. So for example, ice chips or ice cream, which were mentioned before. The outcome then of this fork pressure test can offer insight into the level the product has transitioned to. And so if the sample is smooth with no lumps and minimal granulation, but the fork does make a clear pattern on the surface that is retained once you remove the fork, it could be classified as level 4 or pureed. If the sample has individual particles or lumps that are less than 4 millimeters wide for adults, so the in between the tines of a fork, or 2 millimeters wide for children, but still can be easily mashed with a fork with very minimal effort. The particles can be easily separated and come through the tines of the fork. Then we're looking more at a classification of level 5, minced and moist. If the sample, after it has already transitioned, can be cut with a fork and does break apart, but really requires some increased pressure, so more getting at that blanching of the thumbnail, again, tight pressure, it could be classified as a level 6, soft and bite-sized. And this is where that size requirement comes back into play. So for those of you who are familiar with IDDSI, you'll recall that level 6, there are size requirements on the food itself, such that the bite-sized pieces do not exceed 8 millimeters for children and 15 millimeters for adults. So again, the 1.5 by 1.5 centimeter testing sample, that's simply for testing the transitional product itself. But if we're looking for it to transition to, say, a level 6 or a level 5, then we do have to also consider those particle size requirements that would happen after the transition takes place. So it's not the pre-transition product, but after the transition takes place, have we met that requirement? Significantly, though, we actually do not know what the relationship is between that IDDSI benchtop testing that I was talking about, so that's sitting in water for 1 minute before testing, and actual mouth behaviors. So for example, if we look at the liquid that the food is sitting in, with the IDDSI method, we're talking about water, a pH of about 6.5 to 8.5. When we're talking about oral conditions, we're talking about sitting in saliva. We know that saliva is a biofluid. It initiates carbohydrate digestion. We know that mucins provide slippery bolus coating and that the pH can be closer to 6 to 7. So that is a difference there in terms of the liquid that is essentially processing that product. The IDDSI method, there is no defined temperature for the testing. Presumably it's often tap water. Whereas in oral conditions, we know we're talking about 97 to 99 plus degrees Fahrenheit. In terms of time, the IDDSI method specifies a 1 minute liquid bath, whereas in the oral conditions, oral transit times vary. So we might be looking at a 1 second oral transit time up to 12, 13 seconds in healthy adults. And then finally, the quantity of liquid. So with the IDDSI testing method, we're specifically using 1 milliliter of water. Oral conditions, again, are completely variable. So secretion rates vary from 0.33 to 2.3 milliliters per minute in a healthy individual. We know we often are working with individuals with xerostomia or dry mouth that also have significantly less quantity of liquid in their oral cavity. We also know that not all foods may behave the same despite being classified broadly as transitional type foods, as Reva discussed earlier. So recall the American Academy of Pediatrics does recommend starting with finger foods that are easy to swallow, cut into small pieces, and are soft. And these criteria actually match a lot of the criteria that we also use for older adults and adults with dysphagia, as well as pediatrics and pediatric individuals with dysphagia. So Awadallah and colleagues in the study that was mentioned earlier, they tested 9 products marketed as first finger foods, testing them both fresh as well as when they were exposed to air for an hour or more. Using these adult testers, each product was consumed without using their teeth and then rated based on the time taken for the product to become soft and break up, the time for each product to dissolve completely or become small enough that it had to be swallowed, as well as testers' comments related to product safety. Notably, the most commonly failed criteria was softness, with only 2 products, or actually 2 flavors of the same product, meeting that criteria. And that's one of the key variables that we really are considering when we're talking about transitional foods and the safety of transitional foods. And so while many of these findings were based on more subjective measures, and the study was not intended to address the safety needs specifically of individuals with dysphagia, what we can take away from this is that not all supposed transitional products behave the same way, particularly in the oral cavity. Thus, it is clear that as speech-language pathologists, a number of questions remain regarding the clinical implementation of transitional state foods. So for example, are all transitional foods created equal? How do we address that? How do we target and address that in our clinical practices? And what is captured or not in currently available testing methods? So I'm going to spend a few minutes now discussing a recent study that we published, actually attempting to address these very clinically relevant questions. The study specifically addressed the following. So first, how is the dissolution of solid foam, so that one product of transitional foods that we said we were going to focus on, how is the dissolution of those products influenced by different in-mouth conditions, so time, pressure, saliva? And secondly, do different transitional foods perform differently based on the IDDSI transitional food test? So just to give you a brief overview of what the study entailed, the study included individuals ages 50 years of age or older with or without xerostomia and with or without dysphagia. All the study procedures took place in a semi-private booth pictured here that each had an IOP with a bulb, a glass of water, a fork, and a camera. Each participant, before receiving any samples, was actually trained on what 17 kilopascals of tongue pressure felt like using an IOP. And this number was selected because this is the value that's the estimated thumb pressure used in the IDDSI fork test. So similar tongue pressure to similar thumb pressure in the IDDSI fork test. Then each participant was presented with 4 de-identified samples of each snack that we used. The samples were placed in the participant's mouth and then expectorated. The sample was then examined, photographed, and the IDDSI fork pressure test was applied to determine whether the product transitioned or not. The mouth was normalized with a glass of water using a rinse, and then individuals rested for a minute between intervals. So here were the 5 products that we tested, so all commercially available transitional foods. Given that the Savory's cracker is actually intended to be served with dip in order to meet nutritional requirements, both the cracker itself in isolation as well as the cracker with a dip were tested. And the different conditions that we did to look at time and pressure, so all 5 samples, an individual completed all 4 of these conditions. So they had the sample in their mouth for 5 seconds with no tongue pressure, so the sample just sitting in their mouth. The sample sitting in their mouth for 5 seconds with that consistent, constant 17 kilopascals of tongue pressure. The sample sitting in their mouth for 12 seconds with that consistent tongue pressure, and then the sample sitting in their mouth for 12 seconds with more of a pulsing tongue pressure, so kind of a tongue mashing pattern. So no teeth were involved in any of this testing. We ended up having 30 adults participate, 17 females. The mean age was around 66, 67 years of age. 33% of the sample did self-report experiencing dry mouth, and 27% of the sample did report experiencing dysphagia. There were a few allergy restrictions among these individuals. So one participant could not eat the eat bar due to a dairy restriction, and 2 participants could not eat the shrimp chips due to a crustacean allergy. So I'm going to get into results, and I just wanted to clarify that when I refer to dissolution here, I actually mean the presence of a positive fork pressure test, or a fork pressure test that did confirm the product indeed met the definition of a transitional state food based on IDDSI testing guidelines. And so this first slide here just shows across the 5 different snacks and across the 4 different conditions, as well as an average across those 4 conditions, what was the percentage of these products actually transitioning and getting that positive fork pressure test. And what you'll see is that there were differences across these different products. So we conducted a generalized linear mixed model to compare the dissolution rates via fork pressure tests between snacks across all conditions, and found significant differences in dissolution rates for all pairwise comparisons except for the Savory's cracker versus the Savory's cracker with dip, so those 2 performed similarly, and the shrimp chip versus the eat bar. Those 2 performed similarly as well. And now these results here don't actually show the Savory's cracker plus a dip compared to the other conditions because it followed a similar pattern to the Savory's cracker. So what you'll note is the Savory's cracker versus shrimp chip, Savory's cracker versus baby mum mum, Savory's cracker versus eat bar, shrimp chip versus baby mum mum, and baby mum mum versus eat bar all show differences in their rate of dissolution. When looking at dissolution rates between individuals with dry mouth and non-dry mouth across all 5 snacks at 5 seconds, we found that there was indeed a trend for improved dissolution among those individuals who did not report experiencing dry mouth. However, by the time we got to 12 seconds, so that condition where the sample was sitting in the mouth for 12 seconds, those differences were no longer present. So again, we did see differences in dissolution rates across the snack types when specifically looking at those individuals with dry mouth. So those results are presented here, that again, at 5 seconds, individuals with dry mouth had different experiences of dissolution across the different products tested. Finally, when looking at dysphagia status, results comparing dissolution rates between individuals with and without dysphagia across all snacks at both 5 and 12 seconds did not actually reveal any significant differences. However, similar to before, we did see differences in dissolution rates when looking at those individuals with self-reported dysphagia across the different snack types. And here were what some of those rates looked like. So the final thing we did outside of testing it within the oral cavity was testing it following standard benchtop IDDSI preparation method, so that 1 minute liquid wash or liquid bath. And while chi-square test statistics couldn't be calculated for this data, there were generally higher odds of benchtop dissolution for the Savory's cracker, the Savory's cracker and dip, and the Eat Bar as compared to the shrimp chip and baby Mum Mum. And so you can actually also see here from these pictures that the ending level of the samples after transition did at times vary product to product. However, we did not specifically focus on the specific level that the product ended at as part of the current study. So we do not actually have data to report on that currently. So specifically related to conclusions from this study, it is clear that not all self-described transitional state foods will indeed act as expected in the oral cavity for every patient to the same degree. There was wide variability in the degree and speed of dissolution in these transitional foods, especially in the oral environment. Saliva quantity can certainly be a factor. Individuals with dry mouth might experience a slower rate of dissolution of certain transitional foods, but not all. Also, pulsing tongue pressure did seem to improve dissolution, particularly for those slower dissolving foods. Further, a higher percentage of fork pressure test positive results were obtained on the benchtop preparation method as compared to the intraoral preparation method. And so these increased dissolution rates using the standard IDDSI preparation procedures suggest that using the standard IDDSI protocol alone may not accurately represent a given individual's performance with a particular product. These findings do suggest that in determining clinical utility of any given food, we likely need to consider the post-oral processing consistency, because that is what is ultimately actually swallowed. Thus, even though a transitional food may start at a level 7, that's its beginning stage, what is most relevant is actually what it transitions to in order to understand what patients can include in their diets safely. And so ultimately, we need to be assessing dissolution on an individual basis due to patient-specific oral conditions. So what next? What does that mean for those clinicians who are out there in the audience? I wanted to just take a moment and present some best practice recommendations. This was taken from a recent expert review looking at texture modified foods. And this work was actually aimed at individuals at care facilities, but it's most definitely applicable across the lifespan. And so some recommendations that they made for the improvement of texture modified foods that I think are highly relevant to our conversation about transitional foods include the need to have specially made, nutritionally enhanced texture modified foods, specifically enhanced with energy and protein dense ingredients. We need to be offering a variety of options, so flavors, optimal texture and thickness ranges, as well as increase food attractiveness. We need to increase diversity and offer a range of alternative meal choices and protein and energy dense in-between meal snacks, so that benefit of in-between meal snacks. And we need to provide tailored support. So for example, more time to eat, a quiet environment, and also finger foods were listed on this. And I think transitional foods have a real place and a real opportunity for addressing most of these recommendations that I've highlighted here. So allow me to add a few final research bites, and these will be indeed little bites, and I'm happy to talk more about any of these studies later or offline after the webinar concludes. And so I'm going to start a little more narrow when it comes to eating and swallowing, and then move wider. So first I want to talk about the role of self-feeding, and also I figure by this time of the night you all need some happy pictures. So here are some very old pictures of my children back when they were babies and smaller children. But we know that self-feeding is a crucial part of the eating process, and we want to promote that. Hence the finger food recommendation that we saw on the previous slide. And I believe that this can be accomplished through transitional foods that may allow for safer finger food options. So in some of the previous work completed in my lab, we explored the role of arm proprioception, or sensation from the arm during self-feeding, and other eating and swallowing related actions. And in particular, we found that adults begin to open their mouths sooner when they have that proprioceptive information as compared to when they do not, such as when being fed by someone else. Further, older adults actually begin this movement earlier than younger adults do, and in fact, open their mouths wider as compared to younger adults. And now, while my studies were specifically performed in the adult population, the results actually do mirror research that has been completed in infants and children, as well as in utero, really supporting a relationship between hand-arm movements and mouth movements, particularly during eating-related tasks. So again, transitional state foods really offer that opportunity to maximize proprioceptive information and maximize safe self-feeding. Another line of work that we have completed has examined the role of visual models or behavioral mimicry in eating and drinking. So among healthy younger and older adults, we have actually found that observing another person drinking, even when completing a task that is completely unrelated to eating, this promotes increased drinking behaviors. We are currently in the process of writing up the results from a similar study that we completed in the nursing home setting, in which we found that eating while someone else was eating the same meal led to increased intake among individuals with dementia. And so while family members or caregivers may be less likely to consume texture modified foods, transitional foods can offer a kind of safe for all option that can further promote increased intake by having all individuals be able to snack on the same product and perhaps maximize some of this visual modeling or behavioral mimicry effect. Moving more broadly, I did also want to emphasize the important role that in-between meal snacks can play for many individuals with dysphagia. So we did recently complete a study exploring snacking habits and patterns among individuals in care facilities. A majority of the residents agreed that snacks are a valuable part of the larger nutritional picture, and they also emphasize the intricate relationship between food and socialization. So allow me to read a few of these quotes. Anytime someone serves food without socialization attached to it, they do not have an understanding of food. They just don't, because that is equal to or more than, the food itself. I look forward to snacking, and it's generally associated with happy times. Snacks are very valuable. It's not just the nutrition that you get, it helps the whole body do what you need to do. I consider snacks a part of the daytime eating ritual. And finally, I think that snacking is really good and good for a person. Snacking can be very positive and should be looked at in a positive way. So thus again, as we consider individuals with dysphagia who may in particular require a texture modified diet, we must prioritize opportunities for increased, easily accessible in-between meal snacks, including snacks that promote participation socially with others. So finally, I just wanted to end with one final reminder that builds on what I have been talking about and just mentioned, and that is that mealtime and eating success relies on individualization and socialization. It's not a one-size-fits-all approach. One individual with dysphagia is one individual with dysphagia. And so in order to maximize health and quality of life outcomes, we must constantly challenge ourselves to really find ways to improve the food we offer and context within which that food is offered that still can maintain safety for the patients and individuals that we are working with. So to end, what can clinicians do now? Where can you go next? What can you do from here? First, we as SLPs must create multidisciplinary teams. We have to be working with dietitians and other healthcare providers. Eating and meal times really are about nutrition and quality of life. That's not something we should be doing alone. That is something we need to be working on as a team. And so as a piece of that, we should be exploring as a team opportunities for increased safe snacking. And this is where transitional foods can play a particularly valuable role. So transitional foods really can help individuals have their food fit their lifestyle and established eating behaviors. It can, first of all, fill a gap in IDDSI level 5 and 6 categories. So for those of you who might work in hospitals and nursing homes, you might know that these level 5 and 6 categories often don't have a lot of options, especially easily accessible pre-made options. Transitional foods can offer increased variety and option. Transitional foods can offer appropriate snacking options, so you can have them available on the table or in the cabinet. They're shelf stable, they're easy to transport to appointments or easy to grab as a snack on the go. And also transitional foods could have a role, a therapeutic role in diet advancement. So as someone is moving up and needs more challenging foods, but still in a safe environment, transitional foods may offer the opportunity for mastication, but in a safe way. The final thing that I want to note is really we need to reconsider our assessment protocol. So as I talked about in our study, assessing safety actually requires us to assess the safety of the products that we want to offer and determine how a product responds in our individual patient's mouth, because we know that's going to vary person to person based on all the contextual features and characteristics that we discussed before. We also need to consider assessment of quality of life. So we talk all the time about this balance between a safety need, so to speak, for texture modified foods and improving quality of life. And how are we really measuring quality of life? And how might transitional foods offer that increased quality of life while still maintaining some of that safety? But we do need to think more about how we actually assess that and what we're asking the individuals that we work with. So ultimately, it's really about person-centered and person-directed care. And that's where I know both Reva and I agree, transitional foods really have the opportunity for us to be looking at individual persons and saying, what do you need and what do you want and how can we meet those goals? So I'm going to pop up our email addresses here so you have our contact information later should you have any other questions that you want to ask. But in the meantime, I think we are happy to take any additional questions or comments that individuals have now.
Excellent. Samantha, thank you so much. We have a few questions coming in, and if anybody wants to submit questions, please feel free to do that in the question box below. But my first question here for you, somebody's asking if you know of any naturally transitional foods, particularly for those in countries where there are limited retail transitional food options.
Yeah, I mean, I'll start by saying, some of the things that we think of are probably more along those liquid gel-based type lines. So things like ice, things like ice cream. In terms of more the foam type solid transitional foods, I think looking at what is used for children is probably a first start. What is considered kind of those first finger foods for children. But again, there hasn't been a lot of innovation in this area in the past. It's definitely growing. So I don't know, Reva, if you have any thoughts on that.
Yeah, just in my research of the solid foam variety of transitional foods, you know, and in exploring conversations with people from all over the world at Dysphagia Research Society meeting that had other foods available at that meeting, I really don't see a lot of innovation, like you said, in that category, or the idea of a natural food is a wonderful idea that is transitional. I would have to say nothing really comes to mind. I can tell you, in working with the Food Innovation Center here, they said it was the most challenging thing they've ever done to create a transitional food that matched the texture requirements that were needed, but still offered good nutritional value and excellent taste perception. So I think finding that naturally occurring might be challenging.
Thank you for that answer. I have another question here. Somebody's wondering, how do you measure somebody's quality of life? What's a good objective measure for that?
I mean, that's a great question. And that's something, I mean, there's two thoughts that I can say when we start talking about that. One is swallowing related quality of life. And one is quality of life more generally. So certainly we have the, excuse me, I have a child joining us for a moment. Certainly we can measure swallowing related quality of life with a tool such as the swallowing related quality of life scale. So the SWAL-QOL, SWAL-QOL. There's also been some recent research to support that the EAT-10 could actually be a potential measure of swallowing related quality of life. If we're looking beyond swallowing, there are more general health related quality of life measures that are used in the healthcare literature, and that might be an option. But I think what a lot of the research is showing us thus far is we don't actually have a great tool to measure that at this point. And what I often recommend is just starting with conversation. Starting with conversation with the individual you're working with and with their family, and really trying to get at what it means to them for improved quality of life. What is their goals for therapy? And I know objective measures are often important for documentation and billing purposes, but I think without asking those specific questions, we're still missing the mark when it comes to saying, let's design our treatments around increasing an individual's quality of life. The other thing that I'll note when it comes with that too is just the idea of maybe using some motivational interviewing techniques as well. So again, honing in on what an individual's goal is through motivational interviewing, and then perhaps creating some sort of goal attainment scaling where it's, you know, if your goal is to be able to not lose weight over a 1 month period. Okay, so what is your current status? What would be one level of improvement? What would be the ideal improvement? And what would be a decrease in progress, excuse me. So that would be a thought I have.
If I could just mention that quality of life and food enjoyment are, you know, it's like a component of quality of life. And actually having a scale for food enjoyment, I think it's worthy of conversation. Not that I know of one that exists. Samantha, I think you mentioned that like there is a need for more scale in that perspective, but what could be a conversation point is being able to self-feed is part of food enjoyment, not only just taste perception and those sensorial qualities that we talked about, and then food consumption in general, but enjoyment and life, quality of life, or food enjoyment and quality of life go hand in hand. And so it warrants more questionnaire type development.
Thank you both for those answers. A couple more questions here. The next one, we have a few people on the call tonight that have a diagnosis of esophageal dysphagia, and they eat a modified diet. They're wondering if there's any research that supports eating transitional foods with esophageal dysphagia, and who's the best provider to kind of guide them through what is safe and what's not safe.
Yeah, I can take that one first. So the unfortunate answer is no, I don't think there is research examining transitional state foods and esophageal dysphagia, in large part because there's also not a lot of research on transitional state foods to begin with. I think often recommendations that get made, depending on the reason for the esophageal dysphagia, can include things like a liquid wash to kind of help with esophageal motility, for example. But again, it's a very broad category, and multiple different underlying conditions can contribute to that esophageal dysphagia. I think the GI doctor, or perhaps if someone's being followed by an ENT doctor, that might be a good first step to raise some of these questions. Or if someone has contact with a speech language pathologist, that's also a great clinician to be talking to. And I think ultimately what needs to happen in some of these situations is that clinicians can test it. Clinicians can actually test these products out when someone is undergoing a swallow study to see if it does make a difference.
I can tell you that one of the most compelling emails I got was from someone who tried my transitional foods that had esophageal dysphagia, and she said it was the first time she was able to crunch into food and safely swallow it. And that's one person that decided that it made such a difference that she wanted to email me and let me know. But yeah, just the fact is that she did have esophageal dysphagia, and I found that very interesting.
I'm going to ask you one more question here, and it's kind of more of a comment from a lot of people. An overarching theme of the comments that we received is that people are experiencing barriers with changing their menus at long-term care facilities, skilled nursing facilities to include transitional foods. What guidelines or recommendations do you have for those people?
I'll let you start, Reva, because I know you've had a lot of conversations with individuals in these facilities, including management as well.
Yes, so I could just say that this is back to what Samantha said about collaboration with the dietitian. It's this balanced conversation with where do we input transitional foods into meal planning, because it depends on the relative importance that snacking is playing in that facility and how open the team is to that conversation of increasing that importance to snacking based on the current data that's coming out. So that, in my experience, the players involved make the biggest difference in trying something. Truly, honestly, transitional foods and introduction is innovative, and it is a change for many facilities. But the conversation, I feel, is happening more readily because IDDSI is raising the questions already with regards to testing the food, finding out what levels there are and what is missing, as Samantha said, from the diet and from options, choices for patients, increasing those choices. And they are looking more to ready-made options because they're saying, hey, we have a kitchen staff that can't prepare, a wide increase in numbers of options. We need to have more ready-made options. And so it's almost like a tipping point of the IDDSI has opened the door to having more conversations about transitional foods. And I think conversations beget change. So I think it's the first step. But I can also say that I know specifically about the savory foods that even the crackers can be complementary to, say, a soup. They act like croutons, and they offer that texture to, say, a pureed soup or a mildly thick soup. So it is possible to introduce it to the main meal. I would also say that, if anyone is interested in getting samples, because I think understanding transitional foods is great through a presentation, but actually experiencing it and tasting how it tastes and how it transitions in your mouth is the first step to understanding how it can be implemented with your patient population or in your facility. So we're happy to send those to you if you're interested.
Yeah, and I would just add, and I would build on the point too of what Reva had said before about food wastage. So I think, especially in facilities, the bottom line often comes down to finances and financial resources. And so I think there also has to be that piece of demonstrating a financial benefit of such a product, that if individuals are being served this entire plate of food but not eating the whole thing, here is something that can facilitate the increased nutritional intake at perhaps a lower cost when paired with smaller portion sizes.
Samantha and Reva, thank you both so much for your time tonight on this presentation. I am going to turn it back over to Ed. I think he may have one more question for you, but we very much appreciate you volunteering your time and your expertise to share with our community tonight.
Thank you very much.
I did have a question, but it was really, Elizabeth asked it somewhat in the last minute or two. And that, but I'll ask it anyway. When someone is consuming a food that is unsafe for that person, where is the largest breakdown? Is it the facility? Is it the person? Is it the food server? And you both have somewhat answered that already. Do you have any additional thoughts on that?
I would say that, I mean, some of it is going to depend on the setting. You know, if it does happen that in facilities, kitchens prepare the wrong food, or someone brings the wrong food and someone is eating something that is unsafe, or perhaps someone hasn't had an evaluation and needs an evaluation to determine what is safe. I think when we talk about an individual who has dysphagia, I sometimes want to move away from this idea that they are intentionally doing something wrong if they're eating something that's quote unquote unsafe, because it's the clinician and the medical team who determined what's safe and not. But I do think there is some degree of patient autonomy. And so that's why I love the idea of trying to be innovative in the products that we can offer, so that patients don't have to give up what they want and what they enjoy for the sake of safety. So I guess that's how I would answer that.
I would support that with a little bit of experiences that I've recently had, where patients have described what they're doing because they have cravings that aren't currently being met with the diet that they are being provided. And so they are actually cheating, if you will, and they are eating foods that the doctor or the nurse or the SLP has said, you're not supposed to eat this. And in some facilities, they actually sign a waiver saying they understand their risks, but this is way too important. It's all about that quality of life through food enjoyment, and they're willing to take that risk so that they can satisfy their cravings. I think it depends also what stage of life that person is in, if they have a terminal condition or not. I think that that plays into their emotional connection to the food that they're being offered, and the fact that there is finality looking into their future. So I think part of it is the patient. I really think in facilities, before the IDDSI change and shift has happened, a lot of times people were just given puree and not given minced moist diets or like 5s and 6s because it was safer. You know, it's just, you know, this is just gonna take care of it, you know, and now with liberalizing the diet and this, well, I don't know if it's new, Samantha can tell me, but new to me is just this concept of, no, we're going to liberalize the diet and go to the level that is appropriate for that patient. I think it's upping the bar. So it's putting pressure on the SLPs, it's putting pressure on the dietitians and the food management and the kitchen, and then also the patient. I'm just really excited about the patient having more choices, maybe now that we're evolving this concept and pushing boundaries a little bit.
The concept of a patient signing a waiver really resonates with me. I think that's a really, I don't know, nice way to give power back to the patient while meeting the needs of the facility. So Samantha and Eva, I just want to thank you for taking the time tonight, volunteering your time. I know you both have families at home and they're at home, which made this a little more challenging. But thank you for your time this evening. I'm going to wrap up by just saying to our participants, our audience, if you had questions that were not answered, please email us directly, or Samantha and Rayma provided their email addresses. And we'll try to get you an answer via email. Within a day, you'll get a survey. It takes literally a minute to fill out. It's anonymous if you want it to be, but it helps us shape our go-forward position for what webinars we offer next. So I encourage our audience to fill out the survey that we send out. And with that, again, thank you both. It was a wonderful, enlightening, and thought-provoking topic. It's a lot more confusing, or there's a lot more variables in it than I anticipated. So keep up the great work.
Thank you so much.
Thank you all.
Okay. Good night, everyone.
Good night.